All right. Welcome to one more episode of GNT or G and Tonic or Ghanem and Teixeira webcast. Today we have the honor and a good friend participating on this is Dr. Lillian Craig Dino. I had the pleasure to meet her when I was a fellow at Cleveland Clinic not too long ago. And actually, she was going to her doctoral degree, and it was kind of cool. I learned a lot about nutrition with her and the whole team there. And that's one of the things that I got from my fellowship there was the importance of nutrition. It is so much success dependent on bariatric surgery, right? Because you can have the most amazing surgery, but if you don't do the right nutrition and support and replacements, you can have the worst outcomes ever. But listen, Dr. Craig Dino, I'm going to call you Lillian because I know you for a while. So, welcome. I'm going to let Ghana talk a little bit and go from there.
Hi, Dr. Craig Zeno, and nice to meet you. And I've seen you present in multiple meetings, and you're definitely on a whole different level when it comes to nutrition. So, can you talk to us a little bit about the challenges and the changes that the patients need to work on before or prior to having the bariatric surgery? Obviously, we always say bariatric surgery is a tool, but the change always has to come also from within, and a change that comes with, of course, the modifying the whole lifestyle and changing the eating habits. And so, what do you think is very important that they should change prior to having the surgery?
Yeah, thank you. So Dr. T, Dr. G, thank you so much for having me. This is such an honor. You make such a valid point. I think one of the most important things is to optimize the patient prior to surgery. And that entails not just optimizing their physical nutrition and getting their physical nutrition status up to par, but also their educational status as well. So they have a full understanding about what their responsibility is after surgery. You guys are amazing surgeons. You're going to perform an amazing surgery. But like Dr. T said, what good is performing an amazing surgery if the patient doesn't know how to use it, or if they mistakenly not take vitamins or not do the right nutritional to match the surgery, and then they could develop a bigger problem than going into the surgery in the first place. So what I like to do as a nutritionist is optimize the patient prior to surgery. So what does that mean? That means I'm doing a full nutrition assessment so I can see their nutrition status. As we know, obesity is a form of malnutrition. So a lot of these patients will present with nutrition deficiencies prior to surgery. So if I'm able to correct that prior to surgery, we're already ahead of the game because we know that certain surgeries will certainly increase the risk of vitamin deficiencies. So that's the first thing I do. The second thing I do is provide a lot of education so patients understand the relationship between nutrition and their surgery. I'm not the food police. I don't sit there and say, do that, do this, do that. I try to explain to the patient, look, you need to take vitamin B12. What is vitamin B12? Why do you have to take it? And I explain that to them in a way where they say, oh, okay, that's why I have to take it, because if I don't, I'm going to develop an issue. So I think one of the issues that we have, though, is because of insurance purposes or things like that. Sometimes when we do our nutrition assessment, that could be months before they actually have the surgery. So there's this huge gap between when I first met them and when they get the surgery. And quite frankly, there's a lot of things for these patients to do before they get the surgery. And, by the time they get the surgery, they might be like, oh, no, what did she say? And they kind of forget. So I think a lot of reinforcement needs to continue with the education process and the follow-up.
Yeah, so I agree with you, Lillian. That's one of the things I took away, right? It doesn't matter how successful the most beautiful operation we do or how much weight the patient lose. And one of the patients that really made me a true believer on nutrition importance was actually one patient we saw in fellowship she was 3 years out, bypassed. She had lost, I think, 100 pounds, had a full body workup done. She looked amazing. But when she came to our office, she had no sensation in her legs and arms, all from vitamin deficiency. And that's not reversible, right? You can't reverse that. Once the damage is done, it's done, right? With that said, I think one of the biggest challenge that we have today is the amount of vitamins that we have at our disposal, different brands. Sometimes patients are buying, for example, we do a lot of duodenal switches here in our practice. So we see sometimes patients buying vitamins from $1 store, and that doesn't cut it. So I don't know how you handle that in terms of indicating which brand, or you don't have to say the name of the brand, of course, but how do you guide the patient on that sea of vitamins, or to use patch, powder, capsules, what chewables? So that's the tricky part, you know?
Yeah, you're absolutely right. I think the key to success is to take a patient-centered approach. Okay, one size does not fit all. So that's the same with vitamins. So although I would love for every patient with bariatric surgery to take bariatric vitamins, that might not be feasible for particular patients. Now, what I like to do as a nutritionist is work with various vendors. So if I have a patient that, can't afford a bariatric vitamin, let me see how I can collaborate with some of these companies to say, hey, can you send me some samples or send me some free stuff that I can give to my patients? If a patient says, look, I just can't do these bariatric vitamins, what are my other options? Can I do the buy one, get one free, at a pharmacy? Okay, well, if that's the case, you need to bring everything in so I can evaluate each product. We can't assume if a patient says to you at a follow-up, yeah, doc, I'm taking my vitamins. We can't end the conversation there. We have to find out, okay, what vitamins are you taking? Can you bring them in? Let me take a look at them. Let's read the labels. Let's see what kind of dosages there are. And the most important thing is to get lab work done. You got to get the labs. Everybody's individual. The surgeries, malabsorption, not malabsorption, and even if everybody had a duodenal switch, sometimes somebody might absorb B12 a little bit better than another patient because of passive diffusion. So we need to really instill in the patient, look, taking vitamins is just not enough. You need to come for your follow-ups and get your labs tested so we can see the levels and adjust them accordingly. So if a patient can only afford dollar store vitamins, okay, if that's what you can afford, let me work with you, but I have to have some labs so I can work with you and say, look, we need to get more of this and more of that. So I think that's really important. We just can't say, okay, great, they're taking a vitamin, because in the patient's mind, they're taking the vitamin. You told me to take vitamins, I'm taking them. Okay, but you might not be taking everything that you need at the dosages that you need. So we have to continue that conversation with them.
Well, I think something that you mentioned, and I think we touched about in the two previous episodes now, is you have to take a patient-centered approach, and it has to be, of course, a multidisciplinary approach, and hence the very important role of nutrition. Psychologists come into play as well. And having said that, something that we take good pride in, and that I learned also from Dr. Teixeira as well before as a fellow, and then something that we've championed in many ways is the duodenal switch. But I think that's where we also come in, that when we see the patient in that initial consultation and we take a very good history from them and we tell them, okay, what is your approach on this? We have to tell them if you do the duodenal switch, then just be mindful that you're going to have to taking about 7 to 9 pills of vitamins a day. If he tells me, the patient, or she tells me, hey, I'm not good at taking vitamins, I don't remember. Well, okay, maybe the duodenal switch is not the procedure for you. And that's why it's really not your BMI is this, then you qualify for duodenal switch. If not, then you qualify for that other procedure. But yeah, otherwise you have to look at the patient as a whole, see how their lifestyle is, what their routine day looks like, so that you see if they can fit in those vitamins. Can they take them? Are they going to forget them? They're not going to get at them. And that's where I think also the surgeon comes into play with that as well.
Lillian, so what we're talking about is important, right? Because a lot of the patients forget that a nutritionist is not just, a bariatric nutritionist is not just about talking about vitamins, right? You can use that resource, right? Even to modify your dietary changes, what you can eat, you cannot eat, right? Because I think there are some patients that are able to do a lot of replacement of the vitamins with a good nutrition, right? It's not all of them. That is the importance of vitamins, of checks with labs and so forth, right? And I think, and I tell patients, I think it doesn't hurt every 6 months if you can talk to the nutritionist, connect it, reevaluate. Can we make some changes? Because what you don't want to do is go back to old habits, right? Talk to me about that too.
Yeah, absolutely. So, we do promote that the bariatric surgery is a tool. So we try to teach the patient how to use that tool, and using that tool does include a healthy lifestyle, right? Choosing different foods that they might have not chosen in the past, including exercise. And yes, the diet is going to change as they progress through their journey, as they're losing weight, as they're able to tolerate foods better. So you do want to maximize the nutrition the best you can. So what is the role of a nutritionist on the team? Yes, I love that you guys really believe in interdisciplinary and multidisciplinary. Absolutely. And we need to keep that message equal amongst us as well. So if you guys, the doctors, you're promoting good nutrition and you're saying, hey, look, go see the nutritionist, I can also back you up and say, you know what, this patient is having a little difficulty with this or that. And then I can communicate back to you. So, what we do as nutritionists is we look at what they're eating, we look at the products, we deal with their eating behaviors as well. So we're not psychologists, but we look at their eating behaviors, their eating patterns. Are they going back to grazing? Are they going back to emotional eating? And these are things that we assess as well to say, you know what, doc, I think we need to make a recommendation for this patient to go see the psychologist. So that's how we all work as a team. But yeah, I want to look at what the patients are eating. Are they getting enough protein? Are they getting enough fluids? I know they're afraid of carbs, but carbs are important. Are you exercising? If you are, you need some carbs. So, we like to evaluate the diet at certain points of their journey because things are going to change. So I think the most important message here is from an organizational standpoint, if you can have a program where you're building in the importance of a nutritionist on the team, where we can also be part of follow-up. And the patients, they want that. They want that relationship with the nutritionist. They really do. And, they tell us stuff that they might not tell you, that's just, a different type of relationship. So hopefully that answered your question, right?
No, it's perfect. It's perfect. I think it's important, right? That's why it's important to have psychologists or psychiatrists or whatever you have for mental support counselor on your own roof, right? We can talk about this in a few minutes. I think Dana has a question.
Right. Well, I think something that you started touching about, which is really something that I wanted to ask about because I get asked about it often. And they ask me, am I not allowed to have carbs after surgery anymore? And we always tell them, no, they're important. You actually can have them in moderation. But my question to you, Lillian, is there anything at all that you think you should tell the patients, hey, this you're not allowed to have anymore, not even in moderation, not even a tiny bit?
Yeah, thank you for that question. I used to be very rigid when I was a younger dietitian in bariatrics. I would say, no, you can't do that. No, you can't do that. And I found that doesn't work. So with bariatric surgery, I would say the three things that I'm still a little cautious about is excessive sugar, right? Because I don't want them to get the dumping syndrome. So it doesn't mean they can't have any. So I'm trying to teach them what is sugar and how much sugar can we have in our diet. That's number one. Number two, carbonation. I know there isn't any empirical evidence to show that it stretches the pouch or et cetera, but still from an anecdotal observation, patients that drink carbonation usually have some issues. So I try to keep that out of their diet. And number three, alcohol. Everybody knows me. I am strict on that. I don't budge. And I understand there's cultural and we like it, but I just, from the clinician's perspective, I know, I'm sorry, doc, as you're enjoying your wine, but for bariatrics, it's a slippery slope, so that should also be part of the pre-assessment. Yeah.
Yeah, I agree. So no, it's important. But let me ask you this. Are you as rigid on that subject, a sleeve versus a bypass or versus a switch? So it doesn't matter. You rigid all three.
I'm rigid. Yeah. I just in my 20-year experience with patients with bariatric surgery, I've seen too many horror stories with alcohol. I've seen deaths. I've seen addictions. I've seen weight regain. I've seen DUIs. I've seen crashes. Cancer. It's just not worth it. Liver failure. It's not worth it. And I understand, again, that patient-centered approach. I've had patients say to me, oh, well, then I'm canceling the surgery. And then, of course, you guys are like, Lil, what are you doing? You're chasing away my patient. Well, maybe they're just not ready yet.
No, but they're not ready. I think they're not ready, right? When that is so important, yeah, by far, you're not ready, right? Because the consequences afterwards is so high, that's not worth it, right? So I'm also kind of I'm a little bit rigid on carbonation, right? Obviously, that's a question, right? Because I think if you go to carbonation, even if it's sparkling water, right? By definition, it's a slippery slope. You're gonna go right back to sodas, right? And people say, oh, right? I mean, so it's a slippery slope. And I tell to tell patients like this, you know, you have to be careful what you want to try this cheat day. The cheat day doesn't work, right? I've never seen an ex-alcoholic to have a cheat day, right? And still an ex-alcoholic. That doesn't work. That doesn't work, right? So you still, I believe the obesity is a true disease, right? That needs to be taken care more of a global than just individual thing. It just is not really kind of sort of seen that way as a truly disease phenomenon like diabetes and so forth, right? But I think we're gonna get there one day. Um, I just came back for SMBS Vegas, which was a great meeting, and not to my surprise, but to my surprise at the same time, uh, we had from my all my years, which is about 10 years now, probably 11 years that I'm doing this, give or take. Um, it was the most nutrition I've seen centered meeting that I've been, and it was great because it was a small meeting, and we learned a lot. There was a lot of talk about thiamine and so forth, and the importance and the delay issues you can have with vitamin deficiencies like vitamin A, E, thiamine, B12, and so forth, right? And one of the things I kind of understood was and got out of it, which I kind of already knew from my time there with you guys, was that practices that tend to have nutritionists under one roof with the surgeon tend to have a much more solid nutritionist nutrition background in terms of patient-centered care, right? I don't know if you agree with that. What's your thought on that?
Well, of course, I'm going to promote my profession. And I think, when it comes to my profession, I can do all different fields of nutrition. But I have to say the most rewarding field for a nutritionist is bariatrics, because that's where we're really learning our counseling, what we learned for counseling and biochemistry and anatomy and physiology and nutrition. We really practice it with this population. So it really is a team. To me, it doesn't make sense to me if you perform a surgery on a patient that affects their GI tract, that affects their nutrition, that affects their eating behavior, and you don't even have a nutritionist. That doesn't even make sense to me at all. So yeah, I think, having a nutritionist as part of the team where you can work together, collaborate together, communicate together, that's just a strong program. It just is. And that's what we owe the patients.
One thing that I want to kind of go back on a bit, what we touched about is the things that you're strict on. And it's good to see that we're on the same page in that sense. And we talked about carbonation and sugars. And it just, for those who don't know, watching the show, especially patients who've had the bypass, if you've had a bypass and you drink even a tiny little bit of alcohol, you're going to notice that you're going to get that tipsy effect from alcohol with much smaller quantities, and that's going to go straight into your liver in layman's terms, and it's going to affect your liver just as much as you've had a large quantity of alcohol. That's why patients can get dependent on alcohol who've had bypass much easier, which is why Dr. Craig Zeno was saying she's very careful with that. And the other thing that we touched about is sugars, and I've always tell the patients that there are enough studies nowadays that show that they've done on rats, and it shows that sugar is just as addictive as cocaine. And they've given them cocaine, They've given them sugars and they scan their brains, and the same parts of the brain light up in a similar manner. So it shows you that those processed sugars, particularly, are very, very addictive, which is why we say, okay, maybe you can have it a little tiny bit, but you cannot really do moderation with sugars in a sense. So probably best to just stay away altogether.
Right, right. Yeah, I definitely agree with that. Even when you look at different guidelines, right? The World Health Organization says even people without bariatric surgery should keep their sugar intake to no more than 5% of their calories. That's how we know that, it really could be a problem to health.
So two things. One is sometimes we see these patients, they're a year out, right? They're doing phenomenally, doing well, super happy, change their life, change everything. They're taking their vitamins the way the guide has told us to prescribe to them and tell them how to take it. And we still see some of those patients with some vitamin deficiency. So my question to you is, does the guideline that we have right now, does that need to be revised, do you think, or modified a little bit? Because I think we're adding different operations, right? We've seen a growth of different operations, especially malabsorptive operation like duodenal switches or SADIs or SIPs in America. That I think the guideline that we have, sometimes we have to tweak it a little bit more for those particular patients, right? I don't know if you have a thought on that.
Yeah, I have lots of thoughts on that. Well, first of all, the clinical guidelines that are published by ASMBS, they expire after 5 years or so. So we have to renew them based on the current research. Unfortunately, there isn't good quality research on vitamins and minerals with bariatric surgery. You'd think there would be, but there really isn't. So we work with what we have. And that's why the latest guideline that I was a co-author of, we looked at the research and then graded it. So at least you as the clinician have the final decision. Look, they need more calcium. I know it says, to 1800, but I got a DS patient. They need more. Okay. It's a guideline. It's not a standard per se. Okay. And we have to also remember individual variation, right? Even your surgeries, there's individual variation. So patients might absorb things a little bit better than others, or maybe it's the actual product. So, I think the guidelines give a nice starting place for sure, because it's better than not having anything. I remember years ago as a nutritionist, I'm like, oh my gosh, what do I even recommend? And that's why patients were taking children's vitamins. At least now we know we're getting up to par with the proper dosages. But it has to be tweaked. It does per patient. So some patients might need less B12. I have a gastric bypass patient that has passive diffusion of B12. Her B12 is always high. So she doesn't even take B12. She doesn't need it, but that's going against the guideline. The guideline says you have to take B12. So again, it is that individual approach, but you are right. We've got to look more at the research. We have to revise these guidelines, which, will be happening soon. And we do have to look at global issues as well, because there might be differences. Like we didn't look at selenium, for example. And I know that a lot of my European consorts, they look at selenium because their patients are having deficiencies in selenium.
No, so I think, I think we need to do a complete guideline, especially look at the micronutrients, right? That's very important. But I think, I think we're on the right track. I think my take-home message is practice that do have nutritionists are very important, because they tend to be on top of the patients, and the patients always have a resource available to them. That's why I make sure that the patients know that. Vitamin deficiency is a real thing. It's not something that we're just making up. It is real, right? And you don't want to have it. That's why the replacements are important. Use your nutritionist also as a resource, not just for that, but also for nutrition, to change your life in terms of your diet and adjust things. And also, they will be able to help you. If you can only afford vitamin X, C, and Y, they'll be able to complement and also use the resources that we already have with the connections with the companies to get some supplements, right? I think, in my mind, a successful practice in a successful patient it's not just the surgeon and not just the surgery. Actually, the most important thing for a successful outcome of a bariatric procedure is the nutrition perspective and the mental health perspective, which is the hardest part to change, right? If you think about it, that's the most difficult thing to change. So to me, that is the most center important thing on a practice that we can have.
And I have to say, I really respect a surgeon and a doctor that shows respect to nutrition. So thank you for that. And I think what also strengthens a program is having a support group. Because, a nutritionist can be a facilitator of the support group or the healthcare practitioner, or a surgeon. And this way, patients can support patients. So if a patient can't afford the vitamins, you got other patients that are donating vitamins. It's just an amazing, wonderful community, all of us. It really is a family.
Question. So what is your take about vitamins and sleeves? So do you recommend that patients who've had a sleeve that continue taking them for life? Or do you think that given that they didn't have a malabsorptive procedure that they can stop after a year or two whenever you see that their levels are good and they can stop?
So when you look at the research, sleeve gastrectomy can still have the same deficiencies as gastric bypass up to about 5 years or so. When you look at the population as well, right? So we've got patients that have the disease of obesity that can relapse. They can also still have those vitamin deficiencies. We would have to see the quality of their diet to see if they're actually eating a healthful diet where they can absorb some of these nutrients. I mean, look at the general population. General population has at least one vitamin deficiency. So what is my belief with the sleeve? My belief is, and the guidelines do support this as well, that you recommend virtually the same vitamins and dosages as you would gastric bypass. Now, DS is different. All right, it is, or distal gastric bypass is different. But I do recommend lifelong vitamins and minerals for sleeve gastrectomy. Which ones and how much, again, is on that personalized level. How much B12 do they need? Do they need, how much calcium do they need? Hey, look, even though they might eat yogurt, they might not be able to get 1,000 milligrams of calcium a day. And what am I going to wait for? For doctors to say, oh my gosh, your patient has osteoporosis now. I'm in the field of disease prevention. I want to prevent it. So the short answer is yes, they need vitamins and minerals for life, even if they have the sleeve gastrectomy. Which ones and how much depend on the patient, the intake, the labs, etc.
Lilia, thank you so much for your participation. I know you're very busy doctor, a very busy nutritionist. Thank you for your contribution to the nutrition, especially on the last guidelines, which is a great guidelines that we had. It was probably one of the best ones we've seen that came out from SMBS, the updated one. Listen, let's do this more often. This is great. I think I learned a lot, gonna learn a lot, and the patients, whoever's going to watch the audience is going to learn a lot. It's a lot of good information here. Thank you so much for participating.
Thank you, and thank you for all you do. Thank you for all you do.
Thank you for coming.